Great. Well, I want to welcome you all. My name is Marty Mascari. I am with the North Central Texas Area Agency on Aging. Thank you for joining us today. We have another great webinar in our partnership with the James L. West Center in Fort Worth, and managing physical behaviors in dementia care. And before we get started, I would like to ask Jamie Cobb with the James L. West Center if she could talk about the CEUs, which are on our next slide. Jamie, you go ahead.
Absolutely. Thank y'all. We are very happy to offer CE credits for nursing, social work, licensed counselors, and anybody that wants a certificate of attendance. You will get a follow-up email with a link to complete an evaluation either this afternoon or tomorrow. You'll get it from Marty. Once you complete that evaluation, then on our end, we will get it processed and we will send you your certificate in the email address that you provide. Please do allow us about 3 weeks for us to process those and get them back to you. The link and the evaluation do close in 7 days, so it will not be available at the end of the day on February the 15th. After that, then we will start processing everybody's credits and get them back to you.
Very good. And we certainly appreciate you guys doing that. In addition to the survey that we'll send out, Jamie's survey, that will be a survey monkey, and that will go out in our first reminder email. There'll also be a survey that pops up at the end of the day today as you log out. We've learned in our round of funding that I used to collect them all the time because we used to provide all the CEUs, and we don't provide them for nurses and that kind of thing. And so I'd stopped collecting them when we weren't providing the CEUs, and I really realized that I needed to do that because I have to have that data. So that one will pop up. We'll ask you to please complete that one as well. That has to do with our funding and what we need. I will also include that link in the reminder email, and I'll make sure that that's at the end, not in the middle of the CEUs connection with Jamie's survey monkey. Very good. Hollie, do you want to do the next slide, and we'll introduce Hollie Glover? Hollie, you're doing this presentation, right, Hollie? Right? Hollie Glover with the James L. West Center is going to be our presenter today. Go for it.
All right. Thanks, Marty. And I put in the chat, you will be receiving copies of these slides. There's a whole lot of information that we're going to go through in the next hour. So this month, we're doing managing physical behaviors in dementia care. And next month, we're actually going to do managing emotional behaviors in dementia care. We'll talk about a few of the emotional behaviors today, but we're mainly going to focus on physical behaviors, why they happen. And so we'll be reviewing a little bit about dementia care. And I know many of you have been on a lot of these educational webinars that we've been doing with Marty, and we appreciate you being here. We will have questions at the end. Marty will continue to kind of watch the chat and will stop me if there's a time that we need to stop and clarify something, but we will leave time for some questions at the end as well. There's my information for those of you who do need your CEUs. I know sometimes they will ask for the presenter's information. And I am the Director of Education and Family Support Services here at the James L. West Center for Dementia Care in Fort Worth, Texas. I have been here for about 4 years, have worked in long-term care, assisted living, and for the Alzheimer's Association. I'm also a certified grief therapist. So I was a school teacher before that for 20 years, went back and got my master's degree and focused on counseling. And so I help take care of family members and run support groups also for those who have a loved one who has dementia. And our support groups are open, by the way, so they are open to anybody. If you are interested in that, or if you know others who need support groups, we have 3 here at the West Center, and we can send you information about that. Here are our course objectives where we're going to talk about physical behaviors, and let's go ahead and jump right in and get started because like I said, we've got a lot to cover. So let's talk about what in the world is combativeness with dementia and when are we going to see it? Who's going to do this? Do we know? Can we kind of determine? But if you'll look at this first statistic, about 90% of people who have dementia, keeping in mind dementia is that umbrella term There's over 100, there's about 130 different types of dementia, Alzheimer's disease being the most common type of dementia. About 90% of people who have any of those different types of dementia are going to become combative at some point during the disease. And we'll talk about there's physical aggression and there's verbal aggression. This time we're going to focus on physical aggression. Next month, we're going to focus on verbal aggression. But let's look at why does it happen? Excuse me. It usually happens during ADL time, activities of daily living time. Why in the world, during a time that we're trying to help them with grooming, bathing, dressing, mealtime, and toileting, why at that time would someone hit, push, kick, spit, grab? Think about that just a second. We're trying to help them, and this is when they become physically aggressive, for the most part. Put yourself in their shoes. Empathy, not sympathy. And think about why they would do that. I already know how to do this. I don't need your help. And besides, I just took a shower this morning, even if it was 5 days ago. I don't know you. This is very personal. There may have only been 3 people in my entire life that's ever seen me with my clothes off, and you're not one of them. And you're coming in and you're treating me like a task. Or I'm cold, or I'm hot. There's all kinds of reasons that it happens. And my brain is dying. And I no longer can control my emotions or my words. And we'll look at that in the next slide. Verbal aggression can look like them becoming vocal, agitated, repeating words and questions, demanding, shouting, and then using language that they would not normally use, using words that our loved one, our resident, our client wouldn't normally use. And why in the world does that happen? So let's look at these pictures here that we have of some actual brains. That brain on the left is a normal 3-pound brain. That's what our brain should look like. That brain on the right is a 1-pound brain at end of life of someone who died from, not with, but from Alzheimer's disease, the most common type of dementia. Now you heard me say that's a 1-pound brain and the other one was a 3-pound brain. If we were together, I'd ask you, what are some of the other differences you see? And I'm sure that you can see it literally has holes in the brain. And a 2-pound difference in the brain, how in the world can we expect the person on the right to act like the person on the left? We can't. Even if they look like the person on the left. Now, I want you to notice 2 areas. We have 2 areas in the brain that control language, and they're kind of here in this temporal area. And our next slide we look at, it'll even be a little more clear. We have 2 language areas in the brain. And for some of you, this is kind of a review, and we'll be getting more into the behaviors, but for others, this may be brand new information. So I want to make sure we hit on it. We'll talk about this again next month also, when we talk about verbal, more emotional behaviors, but we're going to see this with physical behaviors too. The left side of the brain deteriorates more and faster in people who have dementia. So that left language leaves. The left language leaves, and it leaves a little earlier than the right side. And that left language is our day-to-day language, our banter, our nouns, the words we're using right now. But the right side, the right rhythmic remains. That right side that holds that rhythmic language remains. So left language leaves, right rhythmic remains. And think about rhythmic language. Rhythmic, you may have thought of music. So music stays. So that's going to be one of our best distractions with physical behaviors is music, their music. We'll talk more about music. But there's other rhythmic language. Poetry is rhythmic. Prayer is rhythmic. Our Father, who art in heaven, hallowed be thy name. There's other rhythmic. Jack and Jill went up the hill. Nursery rhymes are rhythmic, poetry. But what about A, B, C, D, E, F, G, rhythmic? 1, 2, 3, 4, 5, 6, rhythmic. No stay. Long term. But there's some other things that stay. One time, all of us, when we were young, we heard some words and we heard some curse words, we heard some sex talk, and we heard some racial slurs. And somebody told us, I better never hear you say those words again. And so they didn't store over here on the left in our day-to-day language. They stored over here on the right in our rhythmic language. And they stay. So as these words are leaving on the left and all they have left is what's on the right, they will use what they have. And a person who's never said a racial slur or used sex talk or used curse words will use them to try to get their needs met because it's all they have left. And we'll deep dive more into that this month and next month. So this slide is really good at showing us why do people impacted by dementia have challenging physical behaviors? Well, let's look at this brain. This kind of breaks down the areas of the brain. And as those brain cells are dying, what's controlled by the different areas of the brain? Well, if this frontal part of my brain is damaged, well, look what all stored up there in the frontal part of the brain. This is a lot of what Jamie and I do when we're teaching families and caregivers and professionals. And we may even be looking at their loved one's MRI or CAT scan or PET scan and going, okay, let's look at this. Look at that atrophy, how that brain has started to shrink, or where these holes are literally in the brain, or where the plaque is deposited on the brain. If it's up here in the frontal area or the temporal area, and that's where our reasoning and rational and our filter is, and I no longer have a filter, then I'm going to do and say things that I normally would not do and say. It's where our behavior is controlled, is up here. And we're talking about behavior. So this is a really good slide for teaching and learning and understanding. And again, you are going to get these slides. All behavior that we see is a form of communication. In one way or another, they're expressing an unmet need. And we have to step back and really try to figure out what in the world is that unmet need. Usually a challenging behavior, and this is 80 to sometimes 90% of the time, depending on the statistic you look at, either we caused it, we didn't mean to, we would never do it on purpose, or the environment, something in the environment caused it. So that's why we do classes like this, so that we can go in, we educate ourselves. This is how we treat dementia. They're scared, they're frustrated. Even if it doesn't look like they're scared, of course they're scared. They are out of control. A person with dementia, they don't know what's happening. And then that most common trigger during care time, that activities of daily living time, is confusion. There's too many steps. And if you look back here up in this frontal part of the brain, sequencing is held up here. Think about how many steps there are to getting ready in the morning. Think about how many steps there are to a shower. We can't just say, go in there and take a shower. Wow, there's a lot of steps. Or go in there and brush your teeth. One of my support group members shared about walking in, and she went in and her husband had toothpaste all over his face and he was shaving. He still knew what to do, but there was too much stuff on the vanity. And he did the only thing he knew to do. He picked something up and put it all over his face. He could still shave. She had to accommodate his disease. She had to come alongside him and only set out what he needed to do at that moment. He didn't need her to take over. He needed her to come alongside him. Another thing that will happen is that sometimes they will start to have delusions or hallucinations. So what's the difference? I've put the definition there. If they're experiencing a delusion, they can't tell the difference between real and imagined. Or if they're having a hallucination, that's the perception of something that's not present. Like they may be seeing something or hearing something or smelling something that's not there. Or we may get a challenging behavior because they're bored or they're lonely, and they will create if you've ever been around a toddler that's going to get your, or a child that's going to make you look at them, some of you might can relate that way. I'll get your attention one way or the other. Because you may have a loved one who will stand right in front of you while you're trying to watch TV, or who mirrors or shadows you, who stays right beside you. That can be a challenging behavior. Many times that's out of boredom and loneliness. I don't know what to do. I know I'm supposed to be doing something, but what am I supposed to be doing? And us saying to them, just sit there and watch TV, that there's an unmet need. I'm supposed to be doing something. They're telling you I'm supposed to be doing something by staying right up close. It's where we've got to figure out, what is it? What is it? And it's usually they're needing to be doing something with their hands. We've got to get them busy with their hands. Some other causes why we might have these challenging physical behaviors. One of the biggest reasons is we just don't understand what's happening. I don't know why you're trying to get me into that room and take my clothes off. I don't know why you want me to get in that car. And even if we say it to them, they're not understanding the language, because that same language center that produces the words for them to say to us is the same language center that understands the words that we're saying to them. And even if we say to them, do you understand what I'm saying? And they shake their head, yes. But did you see what I did? I said, do you understand what I'm saying? You may have even shook your head, yes, because I gave you the answer. Yes, I understand what you said. No, I don't. I don't know what you're saying. You can get a challenging behavior when someone's overstimulated, when there's too much noise, there's too many, the lights are too bright. I'm tired. There's too much activity going on. We'll see this a lot, especially at holiday time or people coming around that I'm not used to being around. And then our loved one doesn't have the ability to say, there's too many people in here. I think I'm going to remove myself to the other room. But they can get a fist, or they can spit, or they can yell, or they can throw something. They're saying the same thing. Those communication difficulties, pain. And we've got a whole slide where we're going to talk about pain and how do we assess for pain. So when I worked at the Alzheimer's Association and people would call, and this was a very common call, For the first time, my loved one hit, kicked, pinched, spit, cussed. For the first time, what do I do? Assess for pain. If they've never done it before and it just came from out of the blue, we assess for pain first. And UTIs, urinary tract infections, is one of the first things we're going to assess for. We'll talk more about that in a minute. They may have misinterpreted what was said. We meant we're taking our clothes off because it's time to get in the shower, but for some reason, they think we're taking our clothes off because it's time to go to bed. And we're expecting them to go in there and be in the shower, and we come in and they're laying in the bed. Being treated like a child or talked to like a child, being startled. People with dementia have a very high startle reflex. A conflict with someone and a desire to leave. And we're going to talk about that conflict because of what actually stays intact in their brain. Some of the things that we can look for to see if a person is starting to kind of ramp up. One of the first things we can look for is if a person clenches their fist, even if they're in a sitting position, if they're lying down. When somebody's starting to get aggravated, they tend to close their hands. They will start to clench their fist, go into a frown or a scowl. Eyes will start to move around. They may start to mutter or yell or pace. Another thing that is not on here, I don't know why I don't have it on here. Furrowed brow. They may furrow their brow, where you can just see, okay, they're changing. Something's going on. Some of the things that we can do to make sure that we are not injured if our loved one has ever become physically aggressive, or if we think that they might, these are some things that we want to avoid, making sure that we don't have any jewelry on that can be grabbed, that we do not have hoop earrings, that we do not have a long necklace. If we have a ring like that one there, we wouldn't want to have that on during those activities of daily living, that care time, because the chances of us scratching them are pretty high. And then they may pull back a fist or they may hit. We sure don't want to wear open-toed shoes, and we want to make sure and keep space between ourselves and the person that we're caring for. Now, some steps that we can do for intervention, and we're going to get into some specific behaviors, but I want to go through some intervention steps. Redirection is always going to be our best friend. We're going to try to redirect. And there's four ways to redirect a person with dementia that will almost always work. Number one, I've got the picture there. God's gift to dementia with most people is ice cream or sweet food. They're losing their taste. All of their senses are changing. And if we can get them over onto they can only have one thought at a time. So if they are starting to have a behavior or starting to ramp up, if we can get them redirected, if we can redirect them long enough for them to forget what was upsetting them, this also means we've got to leave right here, because right here is where I'm getting upset. So it may mean I have to walk over there to get this ice cream or to get whatever it is. They can only have that one thought at a time. A person with dementia is losing the ability to multitask, where you or I, some of you right now, may be working on something else while you're listening to me and looking at the slide, but you're writing something. A person with dementia can't do that. Another thing is we want to always keep our hands by our side so that we don't look aggressive ourselves. We don't want to have an aggressive stance, and we always want to only have one person talking when we're in the room with someone with dementia and they are getting upset. The other thing is we need to decide if we even need to intervene, because some behaviors we don't need to intervene. We need to decide, are they hurting themselves or are they hurting someone else, or is this just bothering me? So this comes up a lot in support groups. My husband is going to bed with his cowboy boots on. Okay. Is it hurting him? Is it hurting you? Well, maybe it's bothering you, but is it hurting you? And is it causing more trouble for you to argue with and try to get those boots off? Let him sleep in his boots. Who cares? Let him sleep in the boots. He wants to wear the same shirt every day. Let him wear the same shirt every day. It has a stain on it. It's time to go to church and he's got his pajama pants on. Go to church in your pajama pants. Choose your battles. Of all places that shouldn't judge you or say anything, church shouldn't say anything about coming in your pajama pants. People who have dementia have a very difficult time processing information, and it can take up to 20 full seconds for them to process what you said to them. As we're giving directions and we're breaking them down into one-step instructions, especially mid to late in the disease, it can take up to 20 seconds for them to process that information. Now, you may think 20 seconds is not very long at all, but I'm going to set my alarm here for 20 seconds. And we're just going to have silence for 20 seconds. Now, I'm going to pretend I have someone here with me, and I'm just asking them to sit down. And I'm going to use 2 words, and my tone is up. And I'm going to pat the chair, and I'm sitting as I say, sit here, and I'm going to wait 20 seconds. I want you to hear how long 20 seconds is, okay? Sit here. That's 10. That's 20 seconds. Now, most of us would have already done what? Think about it. We would have said it again. And we may have added to it, I said, sit here. How many times do I have to say, sit down? Now they're reading us. They're picking up on our tone. They're picking up on our gestures. And they may then mirror us. Because I just changed my tone. They may change theirs. 20 seconds is a long time. I have watched people fall on their face and then put their hands out because they didn't even know that they were falling until after they hit the ground. 20 seconds for them to process information. And then when we do give the instruction again, we need to give it in the exact same words again. Don't change the words again. Another thing we need to do is to ask for their assistance. I need your help, not you need to take a shower. I need your help in the bathroom. Could you help me in here? I was hoping you'd be able to show me how to, and we're kind of making it about us. Be very aware of background noise, TVs, radios, and outside noise because they're not going to be able to filter that noise out as well. We mentioned that their senses are changing, including their hearing. Hearing is changing. And then moving to a different location. If you're inside, you might go outside. If you're outside, you might go inside. And if you can't go outside, just go to a different room. When I used to have residents come in my office and they would be very, very mad because you're the one that took all my money. Okay. And I had to call the bank and get that straightened out because I'm using a therapeutic story. Some people call that a lie, but I'm going to call the bank and get it fixed. And then we're going to leave this room because if we stay in this room, in about 30 seconds, they're going to loop back to you're the one that took all my money. I've got to get that fixed on the phone. Boy, I'm glad we got that fixed. And what is that? I think they've got popcorn out here. Come on, let's go out here and get us some popcorn. We've got to leave this room and redirect. So if it's a difficult task, so what some interventions that we can do if it is a difficult task. When they're asked to do something that it is too difficult, this is when we're going to break things down into those simple steps. And for these specific task, I'm going to speed up and start going faster so that we can leave time at the end. You are going to get copies of these slides, but I want to make sure we get through these, and I've got a whole lot of slides. So interventions for the inability to communicate. They will start using the words thing and stuff. You know the thing and the stuff. You heard me say that left language is leaving. The hippocampus is dying. So that's where our nouns are stored. The thing, you know, the thing and the stuff and the thing. So what can we say to that? Show me the thing. What does that thing do? And sometimes they'll be able to say the thing that writes. Oh, the pen. And then we can figure it out. So earlier in the disease, we can use things like show me, show me. But they'll get very frustrated because they can't express their own needs. And that frustration can then turn into a physical behavior. So we've got to look for the meaning behind the words, the meaning behind the actions. Because it may not have anything to do with something flying across the room that they just threw. When we get down to it and we break it down, what it had to do with was they were trying to get something to drink, but they couldn't get anybody to understand that they were thirsty. Show me the thing. I had the gentleman who came up and he was asking for a pen, and the pens and the pens and the pens. And we were giving him everything in the world to write with. And he was getting madder and madder. And I finally said, show me a pen. And he pointed at a Pepsi can. Wanted a Pepsi. So here's the slide on pain. You can typically tell when somebody's in pain and when they're not. You can watch their behaviors. We want to make sure and check for pain first. And here are some signs. They may be being very protective of a body part. One of the residents that I remember was really patting kind of down on her lower abdomen area. And we, of course, are going to check for a UTI, urinary tract infection. Or are they constipated? Do they need to go to the bathroom? Is their clothing uncomfortable? Look for their behaviors. Are they decreased activity level, an increase in agitation or aggressive behavior? In the early stages, you can ask yes and no questions. Does this hurt? Now, many times though, they're going to use the word no. But if they use the word no with that furrowed brow and they're holding their stomach, no. Well, they're telling us yes, but the word they have left is no. Because think about when we learned the word no. No was one of the first words we learned. I had a gentleman whose knee was the size of a basketball with gout. It was so hot you could feel the heat coming off of it. And if you ask him, does your knee hurt? He'd say, no. What was he saying? It's killing me. That's what he was saying. He was using what he had left. Urinary tract infections are very common. And I've mentioned that several times that we may need to get them checked for a urinary tract infection, especially if there is a sudden change in a loved one. A urinary tract infection, if you've ever had one, it's a very different type of pain. It's very uncomfortable. Interventions, always looking for that physical pain. Check them from head to toe. It may be something as simple as they've got their shoes on the wrong feet, and that's uncomfortable. Their bra strap may be twisted. They've got a tag that's bothering them, and they can't verbalize it, but they're taking off their clothes. And we go up and may ask, why are you taking your clothes off? And they're not even realizing that they are taking their clothes off, but it's because my bra strap's twisted. They're doing the best they can with what they have left. There again, urinary tract infections, the number one reason people have an initial combative behavior. Respiratory infections will also trigger combativeness, but so will constipation, exhaustion, dehydration. So if they misinterpret what's being said or done, they may believe that they've already done what you're asking them to do, especially if it has to do with bathing. Water doesn't feel the same anymore. And lots of times they don't enjoy a bath or a shower. So we're going to make sure that we stick to a routine, and we're going to explain what's being done from beginning to end and break those steps down in simple steps, 2 to 5 word sentences. Now we've got to be very, very careful with misinterpretation. Women, many times this happens. A resident is in bed and a woman leans over them, and let's say their blouse is low cut and it is a male resident. And here is a woman who's leaning over me. I'm in the bed and she has on a low cut blouse. And where does his mind go? I'm in bed and here's a woman and I can see her breast. And he misinterprets that this is the nurse's aide who's putting him in bed. This isn't his wife. And he may do something or say something that's inappropriate, but we've got to remember he has dementia. Why did he do it? Now, where did that come from? Was her blouse too low? And should she have been leaning over like that? Those are the type of things we've got to be careful about. Same thing in the bathroom, in the shower. Interventions for being treated like a child. We're never going to scold or criticize someone. We're not going to talk to them like a child or talk down to them or talk about their needs in front of them or announce that they need care. Saying something like, Mr. So-and-so is wet, we need to get him checked. That's a great way to get hit or to get kicked or to get, none of us want to have that happen. We would act that way now if somebody were to talk about us in front of us. And because and we'll talk about it in a minute, their amygdala is what is still intact. They realize whenever they're being talked about. So if they're startled, I talked about they have a very high startle reflex. The vacuum coming on, the garbage disposal coming on, they may startle and it may take them just a minute, especially if it is a veteran, if it is somebody who has trauma in their past or PTSD in their past. So before you go up and touch somebody with dementia, you always want to make sure that you're making eye contact before you touch them, that you approach from the front, and we're smiling. I walk around with this smile on all the time, even when I don't feel like it, because the residents deserve it. And my voice is up. They deserve that. We've got to avoid sudden movements and avoid sudden noise. So you heard me use that word that their amygdala is still intact. The amygdala is the part of the brain that controls emotions and feelings. And this is great that we know that the amygdala stays intact, because what that means is that they can read our facial expressions, our tone, and our body language. Even after they are to the point that they've got a flat affect, they can still read us. They will pick up on our feelings and emotions, but they don't have any impulse control. We have impulse control. Our brain is not beginning to atrophy. Theirs is already atrophied. They have poor judgment. We don't have poor judgment. It's hard to hear. We have to accommodate the disease. They can't. That they can pick up on our feelings and emotions. And sometimes they just need to see another face or hear another voice, because it's just us. And we, especially if they are placed, if they're in a facility, that's where we have the advantage, and we can tag team out and someone else can come. What if they're trying to leave? Elopement, impaired judgment, where they might get lost or they might get injured if they leave, and we can't let them leave. Many, many times they're going on those past memories, especially if it's a time of day. This time of day here in Texas, it's almost 3 o'clock. I've got to go pick up my kids. It's time to get off from work. My parents are going to be looking for me. I had a gentleman who used to come to our day program at about 3 o'clock every day. He was going to take the door off the hinges, and he could if we let him get that far. Now, as I would approach him, I always used his name. I would say his name. I never told him to stop taking the door off the hinges, because he would be telling me, I have to get out of this damn place. And so I would say to him, now my voice, I'm going to mirror him now. I know you do. My smile's gone. I'm mirroring him. I know you do. But could you help me with something first? I need, and hopefully I'd had time to run and get some ice cream. I'd have something in my hand, but I also knew some key words with this gentleman. I knew that he had owned a paint store. So if I could use his name and the word paint, I could get his attention. And if I could just get him to turn and look at me and get his attention, I need your help. And then you can get right back to that. I never said you can't take the door down, but if I could just get him to come with me. Switch him off of that and moving to another area. So the 4 things that we redirect with most often: food, music, their music, animals, and children. And if you don't have real animals and children, YouTube videos of animals and children. We're not going to try to convince them they're wrong. We're not going to scold them, just like I never told him to stop taking the door off the hinges. You can do that in just a minute. I need your help right now. Because if we get into you can't do that, now we're going to get in an argument. We're never going to win an argument with somebody with dementia. Many times they're needing to do something with their hands, and so they may need to rummage. They may need to just be really busy with their hands. Interventions for repeated words, yelling, screaming, and crying. We do need to intervene if this is something that is could possibly hurt themselves or someone else. And some things that sometimes help, it doesn't always help, but sometimes we can, shh, did you hear that? The baby's sleeping. We learned this when we were little, shh. Now there's a difference in shh and shh. I said hush. We're not doing that. But that will work sometimes. Shh. What was that? What was that sound? And they'll get very quiet long enough that we can get them distracted over here. And sometimes they just need to be held. And they may need to be held and rocked while we sing and we're doing a rhythmic motion. Think about what we're doing. We're soothing. We're helping them self-soothe. We're reassuring them that they are okay and that you are there with them. Many times what they have going on when we get down to it is fear. That frontal lobe of their brain is damaged. That controls their personality and their judgment. We're going to use validation therapy and say things like, I know you're scared right now. We cannot take their words personally or react to their words. So what is validation therapy? You can look this up on YouTube as well. A woman named Naomi Field came up with validation therapy. She put the name to it. It's where you connect with the person where they are. It puts emphasis on the emotional aspect of what's being said or done rather than what's being said or done. That makes sense. We're actively listening with empathy and respect so that they always feel valued. Just like with my gentleman taking the door down. I didn't say you can't take the door down. I need your help. He was valued. And you can get back to that in a minute. Using the word okay, I see. Tell me more. Is that right? Even after they've lost their language, even after they go to word salad, which is a lot of but they're mad. Really? I'm mirroring them. Tell me more. What's going on? I can't believe it. And I'm having this conversation and they feel heard. So physical interventions to use when injury is occurring. If someone is biting, you can put your fingers over their nose and they will open their mouth. If someone is grabbing or hair pulling, you can pick up their thumb and they will open their hands. Do not break their thumb, just pick up their thumb. Oh, gotta hurry. If someone is eating a non-edible object, like these beautiful candles here that look like apples, I actually watched this happen. I watched a man pick up an apple candle and eat it. We want to attempt to trade for trade that non-food item for a food item. This is one of the easiest things we can do. Toileting. They are going to become incontinent as this disease progresses. That is part of the disease. They are going back. We were not originally toileting. We were not originally feeding ourselves. We were not originally talking or walking. That's where they are headed in this disease. And they will start to go in all kinds of places, behind the door, in the trash can, in the dog bowl. So a person toward the end of the disease is going to become incontinent. They may be agitated if they are wet or if they are soiled, and you may have some behaviors, some challenging behaviors. Some of the things that we can do, especially earlier in the disease, is put one of these bathroom signs on the bathroom door. We learned that sign when we're very, very little. Also getting them on a toileting routine so that we're going to the bathroom every 2 hours. Undressing in public or starting to take their clothes off, look at why. This is rarely sexual at all. It's almost always because they're uncomfortable. They're too hot, they're too cold, or they're uncomfortable. Sundowning syndrome, and again, I know I'm going past, you're going to get copies of these slides. Sundowning syndrome is where they seem to get worse as the day goes on. That internal body clock could be off. They're not seeing well because the light is changing. They may have been overstimulated during the day. Some things that we can do is we can start to play calming music, really keeping a routine and keeping them busy during the day so that we have this calming routine in the evening, and reducing noise and lights, and having those early evening activities that are familiar, especially things like sorting. I used to have some ladies that would sort brochures for me every evening. So decoding behaviors, I'm going to just skim over these because this is going to be, if you'll go back and reread these, this is where you look at the behavior after it's happened. You're going to go back and identify what triggered the behavior, gather some information so that you can decode the behavior. What happened right before the challenging behavior? Where does it happen? When does it happen? And who's involved? Then you go through this checklist. Who are they as a person? So I had a resident one time that would get louder and louder and louder every time she would see a nurse. She would have very challenging behaviors when she would see nurses in a particular colored scrubs. Well, we got to looking into it. She was a nurse herself. We weren't treating her as a nurse. We were treating her as a patient. She needed to be treated as a nurse. We started letting her go into the nurse's station. We started letting her sit in on care plan meetings. We started talking to her like a nurse. The behavior stopped. We had to look at who she was as a person. What's their level of dementia? How are they feeling? What are you communicating? Are they reading your body language and your tone? What's the environment? And then what are their patterns? Here are the top 10 behaviors that do respond to medication. And again, this is something you would talk to your doctors about, because all we can do as far as medication goes with dementia is we can treat the symptoms. And these are the top 10 symptoms that do respond to medication in most people. And then with the summary, because again, I know we've got some questions. All behaviors have a purpose and is triggered. And many times it's triggered either by us or by the environment. Whether it's physical or verbal, that person with dementia is usually afraid and they're feeling out of control. Or there was just a reason that they did what they did. I had a gentleman who was walking along. He came to a mop bucket that was in the floor. He picked it up and he threw it. Well, why didn't he go around it? Because his brain is damaged. He moved the mop bucket. He moved it in the best way he knew how. He picked it up and he threw it. You or I would go around it because we don't have brain cells that are dying. Reassuring them that they are safe and that you are there with them, and then giving them as much control as possible. And I've got an example on there that says pills. I had a resident at one point who just wanted pills all the time. She wanted her pills, her pills, her pills, her pills. So again, we've got to meet them where they are. We made her this big, nice pill box, and we filled it full of Tic Tacs. And she had pills for everything she needed. She had red pills and orange pills and green pills. Therapeutic story, but we met her where she was. It took care of the behaviors. She was beating on the nurse's station door for her pills. We got her some pills in a pill box. They need to feel valued. They need to feel that they have purpose and that they have choices. We can't change the person, but we can determine the unmet need. And we can change how we respond to those challenging behaviors. And then I put there in bold, a person with dementia is not giving you a hard time. They are having a hard time. Please remember that. I've got that on a sign in my office. A person with dementia is not giving you a hard time. They're having a hard time. All right, just to review our CE information one more time. Jamie, do you want to hop back on and go over that real quick?
Yes, I can. Thank you. We will be providing 1 hour of free CE credits for nursing, social work, and licensed counselors, and a certificate of attendance if you would like one of those. The evaluation does close at end of day on February the 15th, and then we will process those CE credits and give those to you within 2 weeks or 3 weeks of today, 2 weeks of that date. I will say you do need to attend the live program to get the CE credits. Marty will be sending out a recording of the program. We're not able to offer credits off just watching the recording. So just clarifying that. So thank you.
The recording will go out in a couple of weeks. We've got to process it, and then we will upload it to YouTube, and then it will go out as a YouTube link. We send two follow-up emails. The first follow-up emails only goes to the people that attended today. And it has the link to the slides, and it has the evaluation link for the CEUs. And I don't send that out to everybody because I don't want to confuse them. They don't qualify for CEUs unless they participated today. The second email will not have the CEU information in it, but it will have the link to the recording, and that goes out about 2 weeks from now. It will also have a link to the slides. I have posted the link to the slides, presenter slides, several times in the chat today, but you will also get that in the follow-up email. It will probably go out tomorrow morning. My billings I'll do today, and I'm still working on it. So it's going to be tomorrow morning before I get the follow-up email out. If you're joining us by phone and you're interested in CEUs, could you please just email me your phone number with your name and your email address so that I can link those together and know who the phone number belongs to? Because there's no way, and we don't have the time to be calling everybody to find out whose phone number it is. So if you could just let us know that. There were a few questions.
Start answering some questions. Yeah. Absolutely. You can share the slides. You can share the information. That's why we do it. Somebody had also mentioned, not all medications are appropriate with all residents, and that's absolutely right. Everybody's dementia, everyone has an individual. It is not cookie cutter. So what works with one person does not work with another. And certain, like Lewy body dementia, for example, there are certain things you can't do. Parkinson's, there's certain things you can't do. But that's why we're not the doctors. We're just providing some information. You always go through your doctor for that. But there are some symptoms that can be treated. Somebody's asking, are the CEUs only for those in Texas, Jamie?
Yes. I mean, we just have certified through state of Texas, but other people will, we can give you a credit, and a lot of states do take the Texas designation.
They're only licensed and approved for the state of Texas, but again, some other states have taken them. I've heard that before, but you take it at your own risk.
And there's somebody noticed Jamie had a new last name. They said, did Jamie get married? Jamie did get married. For those of you that noticed, Jamie had a last name.
Congratulations! We should have started off. We should have started off 20 minutes early with the big party. Congratulations.
Thank you. Thank y'all.
Here's someone saying, can dementia trigger digestive issues? My mom just started getting bloated after a few bites of food. Of course, everything is controlled by the brain. So eventually, I would absolutely go through your doctor first to see what else is going on. But can dementia trigger some other digestive issues? Absolutely, it can. But you're going to want to check with your doctor also to see if there's some medication or, what else could be going on. All right, we're right at 3. I actually have another call I've got to go jump on.
Thank you all so very much. Thank you everybody for joining us. Look out for the follow-up email, and we will also have some information out about our next presentation, which will be on the 8th of next month. Different time, but same day. Thank you all.
Thank you.
Take care.
If you have questions, email us or call us. Thanks. Bye-bye.